more crazy little things. Yeah. Okay, very nice. So as I said before, the labs are not. This is a decision I made a while ago. It's not. You're not going to be graded by lab stuff. The idea is really to complement everything that you guys see, in class. It is supposed to be, and hopefully you guys can go to the lab because it is fun and not necessarily because you have to. Okay, so the idea is to give you some sort of exposure to what's really done out there. The second part is I have your quizzes here, the last one. So on your way out, pick it up. Janet has told me about lots of questions about, are you going to not do something with the first quiz because the first quiz was this and that. Again, the only thing I don't want to do is to get, especially the ones that did well, to penalize those. But yes, I'm gonna. If you have seen an increase in your grades and you see, oh, that looks good, I try to take all this into account. You might get to a point where I say, maybe you're out of the. I believe we're gonna have 4 or 5 quizzes at the end. Out of those, one, the lowest grade we can remove. Okay, so that way, even the ones that did well still can get your lowest grade and remove them, so that can be fair. So it doesn't have to necessarily be the first one, but whatever that is. I'll try to go with that. I know it is nobody believes me when I say those things, that things will go well, but it will. But, just to keep you guys a little calm. So let's restart from where we finished. So I think the very last thing we did was a little bit of maternal recognition of pregnancy, but I think the very last thing that we did completely was the implantation side of it. The thing that I wanna point out, and let's recapitulate a little bit. So we went on all the way from, we had lots of drawings in terms of what happened during fertilization, what happened during those times, that early period of embryonic development that goes from that basically the same size of your oocyte, of your egg, up to 9-10 days of development. The size of your embryo is really going to be constrained by the zone of elution. Okay, so it's going to be the size of the embryo will be the size of what the oocyte was. The only thing is that there's going to be a lot of cell division, a lot of cell differentiation at some point, and that will give rise to then what we call the conceptus. The conceptus is really like this term that we use that is basically the placenta, the embryo or the fetus plus the extra-embryonic membranes or the placenta. So sometimes we say embryo, fetus, conceptus. We use kind of interchangeably every now and then, but I'll give you more or less the definition of those. Embryo is really everything that it's just the embryo itself, and it goes all the way up to the organ differentiation. And that occurs at about, in most species, particularly the species that have by the time you're like on the 2nd month of gestation, you call up to that point embryo, and after that point you call fetus. And fetus is basically when you're starting to look like a little being, a little of your own species. So that's the whole thing. And conceptus is really just a differentiation we make, because every now and then when we do, especially when we do studies that we have to look at the embryo, but you remember when I told you like the embryo starts expanding, starts to elongating. All of that elongation is mostly extra-embryonic membrane. Almost all of that elongation is basically your placenta developing and all this stuff. But you do studies and you collect the whole thing. And we tend to call the whole thing conceptus, which is the placenta plus the embryo. So it's just definitions. If you get confused at any point and I start spitting things on you on conceptus, embryo, fetus, stop me. I'll go back to them. It's not a big deal. And I don't tend to go too crazy on tasks, or if you get the names a little bit, as long as I understand that you're referring to the embryo itself, to me, that's fine. So going back then to the elongation, so you have that rounded embryo up to day 9, 10, zona pellucida hatches. You start to have the elongation of all that mass of cells inside, instead of being constrained by the zona pellucida. Without the zona pellucida, now we can basically elongate, and it elongates quite a bit, okay? Up to a point where you have really like a little, I mentioned several times, a little more like tapeworm sort of form. Up to that point, and that's gonna happen by the time we go to this period here that we call the maternal recognition of pregnancy. We haven't been to implantation, we haven't been to placentation, we haven't been to anything. The only thing is that up to that point, I mentioned it also a few times, that the embryo depends on the product of the endometrial glands to survive. There's no attachment. Whatever that they have to survive has to be there at the lumen of the uterus, of the endometrium there, in order for that, conceptus to survive. And then it comes that very important, moment. And this moment is really this moment, what we call the maternal recognition of pregnancy. So the moment of maternal recognition of pregnancy is basically, if you wanted to define very, very specifically, is the moment where the embryo blocks luteolysis. Okay? So why is that? Now you have to go back a little bit, try to remember the stuff on the ester cycle, and then remember when we were drawing, having a lot of fun with FSHs and estradiol and progesterone and follicular turnover and going back again, blah, blah, blah. At some point, we mentioned that, what makes your cycle to have those multiple waves of follicle development. The only thing that precludes that follicle from growing up until ovulation is progesterone. Okay? Progesterone is really the thing that makes that whole thing, basically the whole cycle, to continue. Okay? At some point, we talked that, in a non-pregnant cycle, what we're going to produce, most species, than to lyse or to kill the corpus luteum. What is the hormone? So as you go into prostaglandin, then you would have then that, that big drop in progesterone. As you have the drop in progesterone, the follicle then can continue to grow up until a point where estradiol is so high, goes into a different center of the hypothalamus, triggers the LH surge, GnRH and LH surge, and then that causes ovulation. Okay, if that happens, it basically means that you start a new cycle, you ovulate. Hopefully, the female, in the case of if you are intending to have a pregnancy, it can be bred or artificially inseminated, and then you can hope for that pregnancy to actually thrive. So imagine that cycle is moving on again. You're starting to go, progesterone slowly going up. You have all your follicular waves and all your estradiol and FSH. The stuff is like that moment that we mentioned on the release of prostaglandin is exactly what the embryo will try to block. Why? Because progesterone is actually vital for the survival of that embryo. Most species, you will have progesterone from that CL, from that corpus luteum, continuing to produce progesterone for the rest of the gestation. It's not in all species. Sometimes you have weird stuff happening, with that corpus luteum, but progesterone always have to be high. Okay, and I will say this in the next class on the parturition, gestation parturition, we'll mention more, but bottom line is you need that progesterone to keep maintaining the embryo. You also need the progesterone to keep your muscles on the uterus to be like quiet. You know, this is one of the most important things that progesterone do, is to keep your myometrium, your muscles in the uterus, quiet without contracting. So it's a physical thing. Very good. So it's a signal necessary for corpus luteum maintenance. Yes, continual endometrial development that then can nourish the embryo, secretory activity. Timing is very important. So I mentioned this a few times before about the timing. And the timing then, why is it important? Because you really have a certain window that the embryo has to be extremely active in order to block that. So let's take, for example, the case of the cow. In the cow, you have a cycle that is more or less 21 days. Okay, it varies 18 to 24, depending on the species, depending on the breed, and so on, depending on the stage of life. But what you do have mostly is like once you ovulate, you have a big follicle here, it ovulates. All of a sudden, this little guy here transforms itself. When I say little guy, the dominant follicle there, it transforms itself into a corpus luteum, okay? And by transforming into a corpus luteum, your progesterone levels do something like this, okay? If you become pregnant, the idea is that you follow this progesterone to be high for another 280 days, which is more or less the gestation of a cow, of a bovine. So the idea is to keep this guy alive. If it is a non-pregnant, as I mentioned before, this progesterone will go down because prostaglandin here is then produced. Okay, PG. And this happens out of that 21-day cycle, anywhere between 17 and 19 days. Okay, 16 to 19 days. This is where luteolysis happens in a normal cycle. Okay. Meaning, that's the window. Your embryo, that right now looks like a little tapeworm, has to actually block this prostaglandin. So what we're going to see in the next couple slides is really how this little guy do that. Okay? So one thing that I mentioned before was that, first of all, the maternal recognition of pregnancy starts or is triggered by the embryo. Okay? It is triggered by the conceptus, the embryo, whatever you want to call it. The thing is, at that point, there's no, as I said before, there's no implantation, there's no placentation, and there's no communication. There's no vessels over there communicating the embryo. So how do you think the embryo at that point communicates with the mother? So first of all, you would have to, in order for you to block prostaglandin, you would have to know how prostaglandin is actually produced. So let's start with where. Where is prostaglandin produced? The uterus. Okay, so it is in the endometrium, in that internal lining of the endometrium. Okay, so if you have, let's say this guy here, so you have this endometrium here. Okay, so imagine this is your ovary. Da, 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 da. So you have your little guy here inside of the uterus. I know it looks like a spaceship, but it's not. But what you have there is that the only way to make that communication happen is that whatever is produced by the embryo has to act in a more like paracrine way. when I mentioned paracrine, is like from one cell to the cell that is adjacent to it. Okay. And in this case, it happens pretty much like this. Whatever is produced by the embryo affects the internal lining of the uterus, which is the endometrium. We didn't go into super specifics when we mentioned about the synthesis of prostaglandin, but the prostaglandin really starts into, you have the if you look at the epithelial, sometimes you have glands going here. So you have like, this is how more or less the endometrium looks like. The endometrium looks like this. You have this superficial epithelium, so you have cells here with nuclei, Every so often you have, what is this? A gland. So you have a gland that is producing all sorts of molecules that is important to the survival, for the survival of the embryo. But these are the cells that actually produce. And then you have like connective tissue here, you have vessels, you have lymph system, you have nerves, you have, everything, okay? This is what the endometrium looks like. So this stuff is like, this is the guy that actually produces prostaglandin. Okay? And actually produces not to the outside, it produces more to here, it's picked up by the vessels, and this is the stuff that, as the endometrium removes all the prostaglandin, theoretically it would have to go to the ovaries through that countercurrent system, blah, blah, blah. So this is the stuff. So eventually this embryo here is going to do something that is going to produce something that, somehow blocks this synthesis of prostaglandin. And you're going to see that the idea here, we're going to give the example of the bovine, but every species have a slightly different way of doing that, okay? So these are some of the actual molecules that are produced. The interferon tau, estrogen sulfate, horses, few molecules, but the most important is equine chorionic gonadotrophin. If it is humans, chorionic gonadotrophin, or HCG. Some of you have heard about this hormone. And the idea is that, yes, common, they maintain the corpus luteum, and they block the effects of prostaglandin. And when I say they block the effects of prostaglandin, it's a carefully worded, kind of little piece, because in some species you don't necessarily block. And to me, this suffices when I explain, and if I ask this to you in the test. The thing is, no, it's not I really don't want to get you into the details of every species and how it happens. I think it is important for you to understand that, yes, that drop in progesterone cannot happen. Okay, and for me, that's the most important, and it has to do with prostaglandin. This guy here, in the ruminants, it does exactly that. Okay, so this guy in ruminants, and you have this interferon tau, and this is the molecule that in ruminants blocks. Estrogen sulfate, for example, that is in swine, doesn't necessarily block the synthesis of prostaglandin. It just diverts where the prostaglandin goes. So instead of becoming the prostaglandin estrogen sulfate, what it does is, instead of this prostaglandin go to the vessel inside the endometrium, that prostaglandin actually goes to the lumen. And that, once it goes to the lumen, it doesn't go to the bloodstream. If it doesn't go to the bloodstream, it doesn't reach the ovaries. And if it doesn't reach the ovaries, it doesn't cause corpus luteum lysis. Okay, so those are different kinds of, strategies. HCG, for example, it is known for actually entering the bloodstream of the mother and somehow protecting the CL. So you see, they have different ways of doing. All of them, what they do, they block the effect of prostaglandin. Okay, so that's the most important thing, and they have to do this by a paracrine fashion, and they have to do this in a very timely fashion. Okay, this is one of the reasons, like, you know, sometimes we do studies in which we collect the embryos. Sometimes this is a very, for us that do studies like in reproduction in bovine, we try to collect stuff, either biopsies from the endometrium or even the actual conceptus that are about that 16-day, 17-day, by not necessarily having to slaughter the animal, but we do the same way we do embryo transfer, we try to collect some of these embryos. And one thing that we saw over the years is that you can have embryos on day 16 that are centimeter, 2 centimeters, and a few that are 10 centimeters, 12 centimeters, and you're like, this is too different. And sometimes I can understand. Sometimes it's 1-2 days of development, and you can go from 1 to 10. The thing is, sometimes that little one could have the chance of surviving, but is not big enough at the right time. Therefore, chances are it's not going to be able to block and is going to eventually die. So the timing, in that sense, it is important for us. I think the other thing that is important to understand is that all of these that we're looking on in reproduction, all the way from fertilization to now, for example, the maternal recognition, and we're going to see placentation, it is just very easy to go south, to go in the wrong way. And that's why, especially, so right now here, we are on day 16, 17. Placentation will start somewhere here, day 20 or so. Organogenesis will finish about day 40, 50. That's why all species, not only humans, we have a lot of miscarriages during the first couple months, or even the first trimester. There's too many things that has to go right, all the way from fertilization to early embryo, maternal recognition, to placentation, and to actually final organogenesis of the fetus that can go wrong. And that's why you end up losing quite a bit of those. Once you pass all of those stages, chances are that you can keep the pregnancy a lot more. So, as I mentioned, this actually happens a lot in most domestic species. Okay? At the same time, for us, if we look not only from the biology point of view, but from the technology point of view, there is quite a bit of room for improvement, increase efficiency, to do stuff that, you know, in nature can be a little bit more inefficient, and we can somehow, either by selecting better animals, either by pharmacological control of astrocycle, or by doing or developing drugs that can increase, you know, this kind of embryo development or embryo or pregnancy maintenance. That is something that is always possible. Very good. Next slide, I think we're going to skip because I skipped the first one. That would be awesome. Nice. So we're going to skip this. Nice. And basically, this slide says, you know, when you have those little tapeworms, and you can see in the sow, you're going to have lots of those. In the case of the cow, you're going to have only one. In the case of the mare, you're going to have this guy just going up and down. So basically, one thing for this, the position of the conceptus, is that because it is paracrine, you're going to have to occupy space. You have to occupy either by positioning the embryo in a way that occupies most of one of the horns, especially the horn that ovulated, or in the case of the mare, which is probably one of the few, is that it travels around. You know, it kind of, you know, up until day, I don't know, 20 or 30, it just keeps moving around the horns, you know, and with that, that is actually very important. In the case of the mare, there is one thing that is a little bit different, is that the zona pellucida actually has even an extra layer of a protection, kind of, you know, it is a very, very big oocyte, a very big embryo. And what happens is that it stays inside for a little longer. And from a practical point of view, what that means is that you can actually diagnose pregnancy very early in mares. By day 14, 15, you can go with an ultrasound and actually see the little guy there because it didn't elongate. The problem with diagnosing, I think one of you have asked me before, the problem with diagnosing pregnancy, when we go, have we shown already the ultrasound or stuff? And the stuff is like, this is how we here, you know, the embryo itself is somewhere here, the rest is the placenta, and eventually that placenta starts to what? Fill with fluid. Allantoic fluid, amniotic fluid, you know, all those fluids that sometimes you hear about it starts to fill. And as it starts to fill up, your uterus starts to expand, grow a little, okay? And as that do, like in ultrasounding, like basically what it does is somewhat similar to an X-ray. Everything that is kind of fluid or air is gonna go, air not so much, ultrasound and air doesn't talk too much, but fluid and ultrasound is something like this. You have like a black space on the screen. And then as you meet something that is more solid, and we call it ecogenic, it starts to have these shades of gray. Okay, so as you have that thing expanding with fluid inside, you can see a pretty big difference of what a non-pregnant from a pregnant uterus. So it's very easy to find, you know, pregnancy at that point. So what you try to do in many species is like, what is the earliest you can detect your pregnancy with very good accuracy? In the mare, because of that little thing that becomes like a little ball for a little longer, you can do it for a little earlier. The other ones, you have to wait maybe a couple more weeks, you know, until you get that. Very good. So this class on immunology and establishment of pregnancy. So this is, I think one thing, I used to have this class at the very end of the course, but at the same time, the reason why I put it here is because, number one, you end up having lots of little, for whatever reason, you have a few, not similarities, but quite a bit of relationship between the repro system and immunology. The second part is that since we have some of the molecules that causes the maternal recognition of pregnancy, or even the luteolysis, are actually inflammatory, pro-inflammatory or inflammatory mediators, I said, let's put it in here so we get done with this. But the idea here for this class on immunology is not that you go and memorize, oh, these are innate immune cells, these are neutrophils, these are cytokines, and so on. But the idea is that you have somewhat of this sense that in reproduction, immunology plays quite a bit of a role. So let's start with the most basic, which is that guy there, this guy, the tapeworm, really is an alien. And when I say an alien, by all means, if you transport that tissue to any other part of your body, it's going to be rejected. Why? Because half of that genetic material is not from the mother. Okay? So then, and I am going to ask you guys that, how do you think that little thing survives? The other thing that is funny is like prostaglandin. Prostaglandin is not known for being a strict reproduction hormone. By the way, it's the opposite. Prostaglandin is part of one of those classes of hormones that we call eicosanoids. It's like super important during the inflammatory process. Almost every cell in your body can produce, but not in the way, not in the post-release pattern that is needed to affect reproduction. Otherwise, any inflammation you had, you would cause abortion, in many cases, but not in that case. So we produce prostaglandin in the reproductive system in a different way, in a different release pattern that it is done when you have an inflammation. Okay, prostaglandin during inflammation is very local. It doesn't go very far. In your case, it goes a little bit, but it's very tight with your uterine tissue and your ovaries. Second part, some of these molecules, such as interferon tau, or even estrone or estrogens and progestogens, they tend to have also immune effect. Interferon tau, the same way as prostaglandin. Interferon tau is known as an antiviral molecule. Okay, every time you have flu or something, probably your interferon tau levels are pretty up. Okay. Progesterone and estradiol, they tend to have more or less antagonic effects. I say antagonic is like estradiol tends to be correlated more to like pro-inflammatory effects. Progesterone tends to be more anti-inflammatory in effect. But that has to do more with in the way estrogen or estradiol and progesterone act on vasodilation. So progesterone, estradiol tends to cause more vasodilation. And if you cause a little bit more vasodilation, you tend to allow cells to reach tissues a little easier, okay, as opposed to progesterone that does the opposite. They tend to be more vasoconstrictor. Okay? So these are kind of weird stuff between immunology and reproduction that happens. I'm not quite sure. I think it has to do a lot with that initial question that I asked about how do you keep this guy. Remember again that I said during fertilization, you have the deposit of sperm cells, and the sperm cells, a lot of them will be killed by the maternal female tract, the reproductive tract of the female. So you have this sort of battle between what is alien to the mother, but also the necessity to reproduce or to perpetuate the species. So a little bit of this, again, especially in mammalians, because in some of the other species, you can lay eggs, you can do other things that is probably a little bit more efficient in terms of how you actually create an offspring. But in mammalians, we chose to do the more complicated way possible, which is, yeah, let's do this. Let's carry an alien for 9 months. It'll be nice. It'll be easy. No, it won't. And part of this is because that little guy is not supposed to be there in terms of how immunology really works. So let's go into, like we talked about a little bit of, some of this, similar to, you have lots of links to the exterior environment. We talked about the physical barriers, or not in that sense, but on the physical barrier, think more on the how the sperm cells, they are killed, once they enter the female tract. But think back on the question of, why and how, or what would be the ways in which you can keep that embryo alive inside the female tract. So before we go into, the innate immune system, the acquired immune system, the idea here is go back to the question. Go back to the question of how do you keep something there. So let's say this little guy here is like, okay, so he passes through the maternal recognition of pregnancy. This guy is a little alien. So what do you do? How would you think if that was an antigen, some foreign body. Normally, how does the body fight something like that? Independent if it is inside the uterus, or obviously the uterus is a special organ in that sense, but normally in your body, what would happen?
The stem cells would have receptors that recognize certain markers.
Yes, so perfect. So basically you would have, I mentioned there, you have the innate and the acquired immune system. Both work with this kind of receptors. Some more specific, some more general. I think that's what we have. But overall speaking, your body is able to recognize what is self and what is non-self. Okay. Once you're born, you have a big portion of 1 or 2 chromosomes in your body that is just specifically made to recognize stuff that is like, because of millions of years of evolution, you don't have to actually acquire and taste everything around you to know certain things are not good. Okay? So you have some of the receptors that you're talking about, we call it major histocompatibility complex. You have other names also to different receptors, but they are receptors. At the end of the day, they are receptors. And these receptors are basically some of your cells or all of your cells. They have certain receptors that tend to carry stuff that is inside the cell, show outside to in the membrane as a receptor in the cell, and say, hey, I'm okay. It's like an ID. It's basically an ID. Okay, a passport. Okay, it shows the passport. Some other cells that are more police officers go there. Yeah, you're okay. You're okay. You're okay. Eventually goes to some of them that are cancer cells or cells that have been are infected by viruses or bacteria that are running around and so on. So once they show an ID that is like, this ID doesn't look good, these cells are supposed to kill those cells that the ID is not good. Okay? Sometimes they phagocytize, sometimes they induce apoptosis in those cells. They do something, but the idea is that you kill. Theoretically, this guy here, once he shows the ID, it would be like half of your passport is okay, but the other half is really not you. Okay? So theoretically, you would do exactly that. You would show the passport, you would show the receptor, all of a sudden, it's not mine, you would kill. Okay? With the sperm cells, it happens the same. Okay, it shows there, little freaking alien with a tail, no, you're done. Okay, you're killed. So the thing is, you're gonna have to have something here that blocks that reaction. So thinking on that, you would say, so first of all is your passport, so your receptors. The second part would be access of those cells that are police officers to this guy. Imagine that you can show the passport, but if there's no one around, well, okay, put it in your pocket, walk around, nobody cares. Okay? So, and the third one, you would be basically what kinds of cells are there to do that kind of surveillance. Okay? So, in many ways, this thing here, obviously you have all these cells. To me, what it is most important that you kind of have a good understanding of this little story that I'm telling. All the other names that are important, of course, but most importantly for this, for the innate immune system, is that these cells here, especially the cells here that makes up all these concepts of what we call trophectoderm cells, because they are cells that will turn into the placenta. And they are the most important. Why? In terms of how the immune system will work with that. Because they will be the ones that will actually attach to the endometrium. Okay, so they will have like actual binding, with the endometrium. So if there is a cell that needs to be somewhat special from an immune standpoint, has to be those cells that become the placenta. Okay. So absence of class 1 MHC. Obviously, we didn't have anything on major histocompatibility complex. You guys have various amounts of knowledge on immunology, but MHC is actually the passport. Okay? So the idea is, if you don't have the passport, and this stuff, most of the time, it works more or less like this. If you don't have anything to show, probably the police officer goes by you and do not bother you too much. It's almost like, more probably the passport is something that you have to show, and if you don't show, you're gonna be done, okay? But the idea here is that it's almost like you have a passport that is like blank. And it's like, maybe the officers goes and see, yeah, it's kind of weird, but you don't look like a criminal, and yeah, I will let you go. Okay, so yeah.
How does the lack of MHC prevent it from being targeted by natural killer cells?
Yeah, so that's the other one. That goes into the second part. You block them to go into the lumen. So it's a combination of things. Theoretically, so those natural killer cells, which tends to be like these guys that kind of surveil a little bit and kills it very quick. So one way is for you to avoid showing some of them, okay? Avoid showing some of this wrong progesterone. This guy here, this hormone that you try to keep it all the way up, through the entire gestation, they tend to be, or it tends to have anti-inflammatory effects. And when I say anti-inflammatory, one of the major things is that it causes a very, very big vasoconstriction. And it tends to make cells not circulate all that much, especially inside the lumen of the uterus. So two of the major ways in which you try to avoid is like, one is the absence of MHC1. The second one is having high amounts of progesterone. So you cut it's not that you cut circulation, but you tend to have very little migration of cells to the inside of the lumen of the uterus. Okay. Are all of this, this is by far, this section that I just told you is by far the most important part for this. We're going to see like little things now. I'll show you like a couple slides on estradiol and progesterone, but all of these cells, if you have had immunology before in your life, these cells, the names of these cells are pretty simple. It's going to be easy for you to understand. And the actual inflammatory process doesn't differ. If that needs to happen at some point, it will happen in the same way as it would happen in another tissue. Okay, so you would have most of the time the innate immune system actually being acting. You wouldn't need exactly a specific response or acquired response, and you would have somewhat in there to kill it. The other part is like this and this is from the embryo standpoint. I'm going to show a few other slides, especially on the estradiol and progesterone, that will show you a little bit of that portion, especially on the vasoconstriction side. But all of the other part of this class has to do with these components of the reproductive tract and the vaginal canal and the cervix, and how these cells here, they can kill things. And that goes back, now we're going back to the side of, more on the, probably, I think the example would be the sperm cells, entering, and how, the reproductive tract can block some are physical, some are pH barriers, some are, but aside from that, it's going to be basically your innate immune system just attacking some of those external cells. So I try to make sure that, during this immunology class, we go, the embryo has a very special circumstance which you want to keep it, that embryo, but the sperm cell is kind of this very short-lived, thing that is inside the reproductive tract of the female. For the sperm cell, there is very little that the reproductive tract does to avoid the killing of those cells. It's not like there's a strategy here with MHC class 1 absence and progesterone to block that immune response. With the sperm cell is a complete war. Okay, so estradiol at that point is high, which basically means you do have quite a bit of cells, neutrophils especially, in the vaginal canal and also in the lumen of the uterus. So you have all of that, which basically means your immune system at that point will be pretty much activated to kill. But the advantage in that case for the sperm cells is that you have a few million cells. So it is impossible for the reproductive tract to basically kill it all. Okay? Now, you can ask something like, and this is something that actually happens in the for certain females, which is, can you, because of this, for some reason, acquire some degree of antigenic reaction to sperm cells? And you can. Okay, so can you, which basically means, can you start creating antibodies against sperm cells? Because, at some point it was, for whatever reason, that thing of a certain antigen of the sperm cell membrane got caught up into your acquired immune system, and you started to create some memory against that cell. You can. Okay, so it can happen, eventually. Very rare, but it can happen. So the second part is this, estradiol and progesterone. We talked about some of these other parts, but part of what I want to say here is this is a little study that they did as far as, you have a control group, an estradiol group, progesterone, and a control group, and then estradiol and a progesterone group. So they inoculated the uterus, and what we saw here is that the amount of bacteria in the uterus, as you have estradiol, is always especially estradiol, is almost always non-detectable. Every time you have progesterone, it is detectable somehow. And the idea is that estradiol, because it is more it has more of this vasodilation effect, it can allow cells to enter the uterus and fight the infection. Okay, that's pretty much how estradiol and progesterone is proven today, to affect immunology. The other steroid that we know very well that affects, immunology would be cortisol, but then it's a different story. Because then defense cells, they actually have receptors for cortisol, for glucocorticoids, and that causes immunodepression. Okay, but steroids and immunology tend to go hand in hand. So they have quite a bit of influence there. So for us, the most important part is it is really the estradiol and progesterone. And let me see this part. This is the same. This is IgG, IgA, IgM, which are the immunoglobulins. Every time you are in estrus, you tend to have more of those in several tissues. And once you're in estrus, what is the hormone that is the highest in circulation? Is estradiol. Okay? So as you have more of those, you end up having more circulation of some of these immunoglobulins, which means you have more access to that immunoglobulins to the inside the uterus. We talk about this, risk of immune rejection, half foreign proteins. So we talk about this way in which you try to do this. The rest, we talk about some of this MHC class 1, you turn off the outer layer trophoblast. So this is basically what we talked. So it's just described here. And talk about, obviously, this immunosuppression. All of this can cause the major progesterone. So it's very important. So for you, if you want to say anything about the immune system and reproduction and the survival of the embryo, this is one. This is the second most important. Okay, the rest is important, but these two are by far the most important. I have a nice little table there that talks about when I ask stuff like it is. I think what I explained during class is what I'm really going to be asking you if needed. But this is one of those nice tables that gives you a little bit more context. And that's it for this class. So now, are we almost done? No. Okay. So let's go to pregnancy and partition. Okay, so before we go, and before we have like, how many minutes we have?
25.
25. So let's give a 5-minute break before I drop down that. Okay.
Yeah. Like I had one of your like I filled in my notes when I took the course.
Yeah.
Oh, I yeah, it's we went over the peak stress. Case study. And they didn't really ask me questions, but I think it's just like, and I like we touched base. HPA access and accessing and just to make sure that they fully understand.
Okay.
I think that's good.
Yeah.
Very good. Awesome.
Looking at the cards.
So for the
Oh, is that right?
yeah, like we think
What?
from the photos, like it's
Really?
very
So they like.
yeah, like the
Right. Very good.
I think we have like we're pregnant.
Let me get just a little bit of water.
I know, right? Turnaround this time. Guys, I thought they were peaking. We're gonna get I continue. I did not think that was coming. We're as fucking overachievers.
Oh. Yeah. I have no idea. But yeah, that's oh, yeah. Okay. I'll just make it. Okay, perfect. Thank you. Oh.
Do you need it? Yeah, you can just got it.
Okay.
Oh, yeah, no, right?
Okay, so before I forget your name. Yeah, it's oh my gosh. Okay. That's so good. Yeah. Okay.
It's just that, I mean, that's my mental stat. I don't know.
I didn't grade this one.
He said that.
Yeah.
So I don't know. I mean, like, I get it, but I couldn't get it.
Yeah. No, I get what you're saying. Yeah, I think one year I can ask Last and Goose. If that's the case, they just I do remember we don't lose touch on how but the thing is it's not it doesn't really text homework per se. Like it does happen, but it's directly affected, not wrong. Okay, can I keep this and I'll check the notes? So we've already done like 90%. Right, but we should like. But I remember I could I'll type again. Yeah. Okay, so since I used to grade this, I haven't looked at it. Or if you want to come because I will my the diagram happened. Yeah, and obviously not identical, but I felt like it was very correct. But I got it.
Not like right where like.
Yeah. You got to go to school. That's all I wrote.
Okay, so let's restart before you guys revolt with the meeting. So let's go with the with gestation or as we move and we pass some of those critical points on fertilization and maternal recognition and implantation, we go then into the remaining of the gestation, and we're going to touch base now on some like very general, information about gestation, but the most important part will be the placentation side, what types of placenta there are and how that is formed, and the final portion, which is going to be the parturition, which is then the other very important step, before we complete the cycle. After parturition, we're going to have a class on basically what happens in the postpartum. Let's see if we can have enough time, for the lactation, all the lactation side, which is also part of the reproduction. science. And then after that, I think we're going to be pretty much, we're going to have another set of labs. Then after the labs, I think we really start the presentation side. So we should be finalizing now this last, few classes actually on information, and then we go on into lab and then presentation. So on the gestation side, from a practical point of view, the only thing that matters to us in terms of length is because of planning. Okay? Obviously, it's the most important side. For humans, it is too, because you don't want to get close to your parturition, in somewhere. Oh yeah, let's go to the Himalayas and do something, So it's not going to happen. But in terms of domestic animals, you try to do that because in many of the production systems, you actually, when you get close to parturition, and I'm not saying the day of parturition, but sometimes a couple months before or a month before, you tend to do special things with different species as they move closer, to the end of gestation. Some of them are because you have to change a little bit the nutrition, either because you have to change the amount of energy that you have to provide to some of them, but also, and in some cases, it's because of, for example, for lactating animals, for lactating cows, you're preparing them for lactation, not so much for end of gestation. But in some other species, you're actually trying to prepare a little bit for the last trimester of gestation because your nutritional needs tends to increase quite a bit. Because we are going to see, or not going to see in detail, but during gestation, you saw that, for that first month, 2-3 months, your embryo is actually very small. Your fetus is not exactly big. You do not accumulate a lot of fluid, but that is exactly the opposite in the last trimester. Then your fetus grows, especially in weight, in an exponential side. You accumulate a lot of fluid, so your energy needs change, quite a bit. What's going to affect some of that? The age of the mother sometimes does affect, as you might have a little bit of shorter gestations when you're younger. Fetal factors, twinning, the sex of the fetus, but especially these two, as far as more applied stuff, they tend to affect the length of gestation. You're going to see that once we study parturition, parturition is also triggered by the fetus. Who initiates the process of parturition is also the fetus. And it has a lot to do with a little bit of stress. It has to do with a little bit of that fetus already kind of not fitting as much into the uterine chamber. So, and that provides, it triggers a certain, a series of responses that have to do actually with cortisol. But the bottom line is basically this. As you have something bigger inside, the chances are that your gestation will be shorter. So, for example, twinning means that, you're going to occupy that space a lot faster. And you're going to probably cause stress in those twins a lot faster than it was like a singleton. The other thing is males. Males tend to, in most domestic species, they tend to be a little bigger. So because of that, they also tend to have a little bit of a shorter gestation. So twinning in males, they tend to shorten the gestation. But that has to do, once we go into the parturition thing, or the process of parturition, you're going to understand a little better. Genetic factors, yes, breeds, they tend to affect, in different ways. And environmental and nutrition, basically speaking, or overall speaking, as you have animals that are undernourished, that you tend to have, and for for animals, for humans, you have other factors like if you smoke, if you use drugs, if you consume alcohol, all of that will tend to affect a little bit the length of gestation, and in most of the time tends to shorten the gestation. Okay. This is more or less the length of gestation in most of the species that we work with. So cattle, buffalo, horses is by far the longest. Swine, sheep and goat is pretty similar. Swine is the shortest. And in some ways, that tends to go a little bit, it follows a little bit the size. You know, as you have bigger offspring, they tend to be or have longer gestational lengths. So if you go to the gestations of elephants, it will be super long. If you go into swine, for example, you have, that's the other part, as you have polycotus gestations, which means a species that have several, you know, fetuses, dogs and cats and swine, you tend to have, comparable to animals of the similar size, you tend to have shorter gestations, okay? So a little bit of this is not going to be the focus on some of the changes that happens, you know, obviously this is what happens more on the macro side of it, you know, to most of these reproductive organs. Some of them are pretty obvious. You're going to have an increase, overall increase in size of your pelvic area, of your uterus, of your ligaments, then of your mammary gland at some point. So the changes that will happen, it will be gradual, but they will reach, obviously, the maximum point by the time of parturition. The vaginal canal, the cervix, the uterus, the vaginal canal and the cervix, they tend to have, they will be, especially the cervix, they will be the door of, it is the door of the uterus. During gestation, obviously, during gestation, what you're going to try to do is to have that door as close as possible. There are two ways for the cervix to do that. One is by physically being very close. The second one is to produce a certain mucus inside that serves as a plug. Okay? Yes.
Why would you get edema in the vagina?
Yeah, so yeah, a little bit, you can have a little bit of that, especially in the beginning, but and especially in the beginning of the gestation and at the very end. But then this is more like in preparation for the two things, but it's not like you stay with edema the whole time, but it's a good one. The ovary, also the pelvic ligaments, you do have some relaxation here, but at the end of the same time, what you end up having at you become a little bit more flexible. So you increase in size, you know, as gestation progresses. Ovary, you have this, it's not that you stop estrous cycle. I think the cessation of estrous cycle is basically saying you have the cessation of estrous cycle in the sense of no more ovulations. Okay? You still have follicular growth, but the only thing that happens is that because your progesterone is always high, you never have ovulations. The only exception to that rule is actually the male, because you do have luteinization of some of these follicles. You don't necessarily have ovulation, but you have luteinization of some of these follicles. So you create something that they call accessory corpus luteum. But this is an exception for, you know, compared to most of the domestic species that we study. Okay? So does it somehow during gestation and during the early stages postpartum, your ovary works more like a very low intensity, so you don't have that much intensity of things. Your hormone levels tend to be a lot more stable, you know, for the most part, because your progesterone is always high. And your progesterone in the same way as estradiol, and because of that, your estradiol doesn't swing all too much. So during gestation, it tends to be a more stable endocrine environment from a ovarian standpoint. Okay. Very good. Most important part, yes, the corpus luteum will persist through pregnancy. Again, a little bit of exception of the horse. The only other organ that will produce some progesterone in a few species is the placenta. The placenta will produce a bunch of actually hormones in different stages. At some point, they will produce placental lactogen, very close to parturition. They will produce lots of estradiol. So it's a very, very, very active organ. You know, it's a temporary gland, if you will. This other part here, in terms of, you know, as I said, placenta, they will influence, you know, lactation because of this placental lactogen. But the only thing that is important to understand here is that, yes, during gestation, you're going to do everything to continue to produce progesterone. Most, or especially most of the species actually will be CL dependent, which basically means if you remove the ovary somehow, gestation will be cut off and you're going to have abortion. In some other species, you have a little bit more leeway, especially in the mare. You can be, especially like in the mare, completely placenta dependent, but this is, again, is an exception. And this is I think the stuff here for the, you know, hormones of pregnancy I think this is more an equine exception. I think I put it here. Don't take this. I wouldn't ask stuff about this, especially this top portion of the slide about the equine. But since it is just an exception, they have like specialized, you know, little structures that are formed in the uterus to produce a little bit of that progesterone. But it's really not. It is more for curiosity. In the metabolic hormones here, the only thing is that during gestation, and this works for lactation as well, you also depend on regular hormones that keeps you, you know, in balance. So insulin growth factor, so IGF-1, growth hormone, thyroid hormone, all of them will have some degree of influence in your gestation. But again, I don't think this is the focus of the class that we're giving. So this slide is much more of a curiosity.
The HCG, is it like made in the placenta? Like, where is that coming from?
Well, it is close to the placenta, and I will explain why. When we say equine chorionic gonadotrophin or equine chorionic gonadotrophin, the chorionic means from the chorion. So the chorion is one of the extraembryonic membranes of the fetus. Okay, so the actual origin, you can say it is the embryo. But the thing is actually a portion of the chorion. It is actually what attaches to the endometrium that forms the placenta. So sometimes you can say that it's formed in the placenta, or it could be generated in the placenta. I think sometimes there's a confusion that people make. But the time is, by this time, when this happens in humans, and you have human chorionic gonadotrophin happening, it has to be before placentation occurs. Okay, so I think the correct one is to say it is from the fetus origin and not from the placenta. Because the placenta, at the end of the day, especially the unit that, you know, when you have the fusion of tissues, it is basically a dual origin, you know, because you're going to have certain things that are produced exactly by the placenta, and then you can say, is that from a mother origin or from a fetus origin? And at the end of the day, it's just both. Okay? Okay, so then we'll start with the placenta on Thursday. And some of you might have asked, yeah, we're not going to have a quiz this Thursday. Okay, so we don't have enough. We're probably going to have a quiz a couple weeks from now. Okay.